Christine Beeton. She undertook her undergraduate and PhD studies actually at the University du Méditerranée in Marseille, France. Jeff, please excuse my pronunciation, and Said. And then she moved to the US to postdoc at UC Irving with George Chandy. And then she embarked on a tenure track work at the Baylor College of Medicine in Houston, Texas, where she is now an assistant professor. So Christine and her academic and industry collaborators in the US have been working for over a decade on looking at different potassium channels expressed on different populations of T cells. And they've been developing small molecules, natural products, and peptide toxins to treat autoimmune inflammatory disease. And in today's talk, Christine's got a very novel approach to this, which is to use a probiotic bacteria to deliver some selective peptide toxins against potassium channels to treat rheumatoid arthritis. So it's my pleasure to hand over to you, Christine. I hope you're there.
Yes, I am here. Thank you for a very kind introduction. I hope that you can hear me well. And so, yes, I am going to talk to you. I'm going to continue on a theme of autoimmunity and targeting ion channels in T lymphocytes for the treatment of autoimmune diseases. And what I'm going to tell you about today is something we started just a few years ago in the lab. And the porta patch has been extremely important in that work, in testing very small samples. So before I get going, I have to tell you about a few conflicts of interest. I'm required by the NIH to do that. Now that that's done, let's talk about rheumatoid arthritis. So rheumatoid arthritis, you may have heard of it. It is a disease that is mainly known for affecting the joints. If it's left untreated for several decades, what you can see is you start seeing swelling of the joints, and then eventually it goes to complete deformation of the joints with an immune attack on the joints and also an effect of resident joint cells. Now, those patients also have other comorbidities, including cardiovascular and respiratory comorbidities. So the effect of rheumatoid arthritis is not only on the joint, but this is where we see the disease most easily in patients. And current therapies for rheumatoid arthritis are generally broad immunosuppressants. So they're going to target either all proliferating cells, or they're going to target a large range of immune cells. And in both cases, what you have is immunosuppression. And with immunosuppression comes an increased risk of cancer and of serious infections. So we got into that field and wondered if there was something we could do to improve the outcome for the patients without having those side effects. So let's go back to look at what causes rheumatoid arthritis. Well, there's broadly two arms to the disease. One is the immune component I just briefly talked about, and there are multiple immune cells involved in rheumatoid arthritis, but the one I'm going to focus on today is the effector memory T lymphocyte, or TEM cells. They are involved in autoimmune responses, and they participate in joint inflammation during rheumatoid arthritis. But there is another component in the joint in rheumatoid arthritis that are resident joint cells. So there are multiple cells in the joint, in a healthy joint, that participate in the normal function of the joint. And today I'm going to mention fibroblasts like synovial, also known as FLS. And those cells during rheumatoid arthritis acquire a pathogenic phenotype, and they participate in joint degradation. So what does it look like if we look inside a joint? So this is a rendering of a healthy joint. The bone is in white. You have cartilage here shown in blue that cushions the two bones. And in between, you have the synovial fluid that acts like engine oil. That's a lubricant that is thick and gooey, and it allows the bones to move freely from one another without touching each other. And then you have this very thin layer of cells And those cells that form the capsule are fibroblasts like synoviocytes. So that is what a normal, healthy joint looks like. In rheumatoid arthritis, though, things look very, very different. So those FLS, instead of keeping this nice thin layer, acquire what often people in the field called a tumor-like phenotype. Those cells lose contact inhibition, so they start growing on top of each other. They produce chemoattractants, so they're going to attract immune cells to the joint. They produce pro-angiogenic factors, so they promote angiogenesis in the joint. And the formation of new blood vessels, of course, helps immune cells come in the joint even more. And then FLS can also produce proteases that are destructive enzymes that can directly damage the cartilage and the bone. And what's very important is that if in an animal model you induce a model of rheumatoid arthritis and you ablate the immune system, the FLS that have been activated don't go back to rest. So those cells are on their own. Once they're activated, they're going to participate in driving the disease. And currently, there isn't a single treatment on the market that specifically targets FLS during rheumatoid arthritis. So we, for many, many years, have been interested in immune cells and especially effector memory T cells in rheumatoid arthritis. And in the last decade, we got interested also in FLS in the joint during rheumatoid arthritis. And so what we found over those decades of work is that effector memory T lymphocytes, both in human and in rat, upregulate the Kv1.3 channel. And we and others have developed highly selective blockers of this channel. And the one I'm going to mention today is SHK186, or also called dalazatide. That's a very specific inhibitor of Kv1.3 channels that preferentially inhibits effector memory T cells over other subsets of T cells. And SHK186 has undergone phase 1A and 1B clinical trials in healthy volunteers and patients with active plaque psoriasis. And now an application has been submitted to the FDA to perform phase 2A clinical trials with it. So I'm going to mention this one a little bit. And then the other channel we're looking at is in the FLS. And what we found about a decade ago is that FLS upregulates the KCa1.1 channel that you may also know as the BK channel. And what we see is an increase in the alpha subunit, the pore-forming subunit of KCa1.1, but also a switch from the beta-1 to the beta-3 regulatory subunit when FLS are isolated from patients with either non-rheumatoid arthritis or rheumatoid arthritis. There, we do not have, unfortunately yet, a specific blocker of KCa1.1 alpha beta 3, which is what we like, but we still have some tools that are not drugs. I don't think they're going to be drugs, but they're good tools to study the role of those channels and the effect of blockers on inhibiting FLS in vitro and in vivo. So we did a lot of work in vitro on those cells. I'm not going to talk about that today. I'm going to show you one crucial piece of data in vivo. So what we did here is we induced a model of rheumatoid arthritis in rats. And in the vehicle-treated animals, so those animals are treated subcutaneously in the scruff of the neck at start of onset of clinical signs. So when we have at least one joint inflamed. As you see here, you see a nice progression of disease in the vehicle-treated animal. When we treat the animals with arberiotoxin to block KCa1.1 in FLS, we see a significant reduction in disease severity. When we use SHK186 to block Kv1.3 channels in effector memory T cells, we see a similar reduction in disease severity. When we block both channels, we see an almost complete stop in disease progression. So that tells us that in the patients, we will probably want to target both cell types to have the maximum efficacy. And so for that, we have a drug and we have a tool. So let's talk about SHK186 a little bit. So SHK186, like I told you, has been tested in clinical trials, is continued to be tested in clinical trials. We're hoping to develop that further. But SHK186 has a downside. It cannot be produced recombinantly. And the reason for that, this is the sequence of the native peptide from the sea anemone. This is the sequence of SHK186. And you see that it has a small non-amino acid adduct. And this cannot be produced by either bacteria, yeast, or mammalian cells. So SHK186 has to be synthesized. The problem with that is anytime you're going to synthesize and fold a peptide, it's going to be expensive. So we spent a few years and we made a number of analogs of SHK186, and analog 235 has two substitutions. So we modified here, we removed the methionine to prevent the risk of oxidation in vivo. And then we did one substitution and one addition of an alanine. And this peptide is as selective for Kv1.3 as SHK186, as high affinity for it. But now it's all natural amino acids. This can be produced recombinantly. So now we have a second generation that has the same properties on the channel, but is probably going to be a lot cheaper to produce. So that's one issue that we might have solved. But the other issue is that all of those peptides, if you go to a venom toxin meeting, a lot of talks are going to say, well, those toxins, those peptides are going to have to be injected. There is no way those toxins, those small, highly folded peptides are going to be able to be orally bioavailable without being destroyed in the stomach and the duodenum. And we believed that for many, many years. I was one of those people who would say, well, we have to inject them. They're well tolerated. It's going to be injections through decades of life. It's not ideal, but as long as it works and has few to no side effects, this will be all right for the patients. But in the back of our minds, you know, injections are not great. And then, you know, we started thinking, talking to other people in other fields, and we came to a realization that we are not alone. And when I say we're not alone, I'm not talking about space aliens. What I'm talking about is our gut is full of microorganisms. For example, a lot of bacteria. And many people ingest probiotics every day. Some of you may have had yogurt during breakfast. You may be eating sauerkraut later today. A lot of different cultures have developed a lot of fermented foods, and the ferments in those foods are probiotic. They are good bacteria, good microorganisms that when you ingest them, they help the health of your gut, and as such, they help the health of your body. So we started looking at those probiotics and we thought, well, can we do, since we now have peptides that can be produced recombinantly, can we do something maybe a little bit weird? So the question here is, can we bioengineer a probiotic to deliver SHK235 or abirutoxin directly into the gut? And so when we thought about that, we talked with Rob Beeton, who is a bacteriologist here at Baylor College of Medicine. And he works with this probiotic called Limoxilactobacillus reuteri LJ01. And it has a specific ATCC entry. And we specifically work with this one because it has some properties that are very interesting in rheumatoid arthritis. So one, it does not colonize the human gastrointestinal tract. That's very important because if you're going to deliver a drug, you want to be able to control when you give the drug and when you do not give the drug. So if we use a bacteria that colonizes the gut, you give the drug and then it's there forever. And that is a little bit scary. So this one does not colonize the human GI tract. So that's a good point for it. The second is that it binds the mucus of the small intestine epithelium. And that's one of the reasons it doesn't colonize. It binds the mucus as we replace the outside layer of the epithelium and the mucus, it gets secreted out, excreted, and we get a new layer of mucus and epithelium. But the other reason we think this is important is because it embeds itself into the mucus. It gets very close to the epithelium, and that might be useful in getting something across the barrier. Then we know that this probiotic has mild anti-inflammatory properties. It has been beneficial. It's not a cure, it's not a treatment, but it has showed some benefit in some patients with inflammatory bowel disease. And then something really interesting is that there are clinical trials, not only studies in mice, but clinical trials in older women showing that this specific strain of probiotic reduces bone loss from osteoporosis in older women. And I am actually taking this probiotic every day now because I'm getting to that age. We're interested in this because in rheumatoid arthritis, there is damage to the bone and there's bone loss. So maybe the probiotic itself could have some benefit. So in addition to all those characteristics that are very interesting and that are the reason Rob Britton studies this probiotic, is also developed tools to genetically modify this specific strain of probiotics. So he's worked out promoters, his signal peptides, all those tools to secrete peptides and proteins. So what we did is we took a plasmid. The system we have right now is plasmid-based. And in his well-defined plasmid that he's worked on for a long time, he inserted SHK235, that's tiny, it's only 37 amino acid, 38 amino acid, with behind an inducible promoter that's induced with a pheromone peptide, and with a signal peptide that induces secretion, and the signal peptide is cleaved from SHK235 upon secretion. So then what we did is we inserted this plasmid into L. reuteri, and we wanted to see, well, does the bacteria produce the peptide? And that's where we have a problem, right? SHK235 has picomolar affinity on Kv1.3 channels. So even very small amounts in the supernatant might have an effect, but there are not really good techniques to detect very small amount of peptide. The one technique there is that can do it is patch clamp. And so we've been using the porta patch for that. And so what we're doing is we have a cell line that expresses the Kv1.3 channel. And then we dilute supernatants from either a probiotic that produces an irrelevant protein or that produces SHK235. And we dilute the supernatant from those bacteria into the external buffer, and we replace the external buffer with this, and we see that in the presence of the gassé, there's little to no effect on Kv1.3. But when we add supernatant from the probiotic supposed to produce SHK235, we see a nice block of the current. And when we do a dose response, it allows us to calculate the approximate concentration of peptide in the supernatant. And we have approximately 400 picomolar, which is pretty good, given that the peptide has an IC50 of 70 picomolar. So that's great, right? It produces it, but that's in vitro. How about in vivo, right? Once you put it in an animal, everything changes. So we did the same thing. We gavaged. So we take healthy rats and we orally gavage either our probiotic of interest or a probiotic that produces an irrelevant protein. We put it directly in the stomach of the rats. We wait 6 hours and then we collect blood and prepare serum from those animals. And then we again use the porta patch to patch clump serum samples from those animals. So there again, we dilute the serum 1 in 10 in the external buffer, and we put it on the cells. Serum from a healthy animal gavaged LR gassé has no effect on Kv1.3 block. If you put serum from rats gavaged LRS to 35, there is peptide in the circulation because we see nice current block. Now, when we wrote a grant to get this funded, the reviewer said, oh, well, you don't need a probiotic. You can just put your peptide in a capsule, enteric coat it, put it in the stomach of the rat. It's going to do the same thing. So we did that. We got those tiny capsules. We filled them as much as we could. We put as much SHK235 as we could in there. We enteric coated them. We gavaged them to the rats. And 6 hours later, we don't detect any peptide in the blood of those animals, similar as if we gavage a capsule filled with gelatin. And the result varies from animal to animal. So we do have a range of efficacy and something we're going to have to work on. But what we can see is that in the majority of animals, when we gavage them, a single dose of this probiotic modified to produce SHK235, we detect current block in the serum of those animals. Now, is that sufficient to actually have an effect on an autoimmune disease in those animals? So what we did is we repeated the trial I showed you earlier, where we have vehicle-treated animals. So again, we start treatment at onset of clinical signs. We give vehicle subcutaneously in the scruff of the neck. Over time, you see a nice development of disease. If we inject SHK235 here in purple, you see that SHK235 injections reduce disease severity quite a bit. If we gavage the probiotic that produces the relevant peptides, here are the blue triangles, you see that over those 2 days here, very early on, we actually have a significant reduction in disease severity, but that goes away over time, probably because the disease is too severe for the probiotic alone to get a hold on it. But very interestingly to us, when we gavage the probiotic that produces SHK235, we almost completely stop disease progression. We are not sure why there is such a difference between those two delivery methods. We have multiple hypotheses. One is that we have a sustained delivery, right? The probiotic stays in the gut for a couple of days. So it can, if it's still alive there, it's producing the peptide. We have a continuous delivery during those 2 days, and then we gavage more. We get that sustained, whereas with the peptide injected, we inject it once a day, but then we have a bolus and it's eliminated through kidney clearance. So that's one possibility. The other possibility is that the probiotic itself is mildly anti-inflammatory. So that combined with SHK235 might have an improved effect. No, those are hypotheses we can test and we will test. So hopefully a year from now, we'll have a better answer about that. Now you might say, we are scoring those animals ourselves, right? We're counting inflamed joints. And we could, even though the person scoring the animals is blinded to the treatment, we could bias ourselves. So at the end of the trial here, we euthanize the animals, we collect their paws, and we do a micro CT to look at joint and bone integrity. And those are pseudocolor. So this is the hind paw of a rat, of a healthy rat. And everything is pseudocolored. So if you see blue and white, it's bone with high density. Red is low density. So if you look carefully here in the metatarsals, you see the joints, but they're nice little thin red layers because that's the space between the bones. Now in the vehicle-treated animals with arthritis, you see this is completely chewed up, huge damage. The joints are chewed up, not only in the metatarsals, but you can see damage also in the toes. If you treat with the probiotic alone, you don't see much of an improvement. However, if you treat with injected SHK235 or with the probiotic producing SHK235, in both cases, you see a dramatic improvement in joint integrity. It's not perfect. It's not back down to what the healthy animals are, but compared to the vehicle animals, it's a huge improvement. So when we got that, we were very happy and we presented that at meetings, and people started asking us, can you do that with any peptide, any protein? What is the limit? Can it work with anything? And the question we have is we don't know how the peptide gets from the bug in the gut to the circulation. So we don't know if what was happening there is very specific to SHK. Is there something special about SHK? Or can this approach be used for other peptides of similar size and later on for other proteins? And since we have aberotoxin, and we know that aberotoxin is beneficial in a model of rheumatoid arthritis, we took the plasmid and we replaced SHK235 by aberotoxin. Same promoter, same inducible promoter, same signal peptide, and we did similar assays. So when we got in a little bit of pickle that the supernatant from the actually kills the HEC cells that express BK, so we were not able to do patch clamp on those. We're still working on solving that, but we're doing proliferation assay on synoviocytes from rats with rheumatoid arthritis in vitro. And what you can see is when we compare supernatants from LRGAC to supernatants from IBTX producing probiotic, you have this decrease in proliferation, suggesting that the probiotic is able to secrete aberotoxin. But maybe more important, when we gavage the animals with either probiotic and we measure the proliferation of the FLS where we use the rat serum from those animals it's not external buffer, it's in tissue culture media, we see a significant, it's not huge, but it's a significant reduction in FLS proliferation. So then we said, okay, let's test that in an animal model. And the trial just ended last week. We thought we were going to be smart. And instead of using the same animal model we've used so far, we decided to use an animal model in which FLS are more dominant. And when we use that different animal model of rheumatoid arthritis, it turns out that LR-IBTX treats the disease really well, but LR-GAC does also. So in this animal model, the probiotic alone treats the disease, which is quite interesting, is not exactly helping us finding out if we're producing enough IBTX. So we're going to have to switch back to our old animal model to test that. But what we have now is, I hope I've convinced you of a few things. One is that targeting both Kv1.3 on effector memory T cells and CCR7 on FLS is more beneficial in a rat model of rheumatoid arthritis than treating either alone. We've also shown that a probiotic can be engineered to produce bioavailable, orally bioavailable SHK235 in sufficient amounts to treat a model of rheumatoid arthritis. And this approach might be applicable to at least other toxins, and we're hoping other proteins and peptides. And to finish, I would like to acknowledge everyone who has participated in this probiotic delivery adventure. I would like to thank our funding agencies, and I would like to thank you for your attention.
Merci, Christine. That's très cool. So we have a few questions, a couple from the audience and maybe a couple online. Yes, okay, Mark.
Hi, that was fascinating. Excuse me, but can you explain to me why blocking a potassium channel in the T cell would help with the rheumatoid arthritis? So what does it do in the immune cell?
Yes, so in the T cell, when the T cell gets activated, it needs a huge and sustained influx of calcium. And the thought is, as calcium comes in, it shuts down its own driving force. So that leads to the opening of potassium channels, and the potassium channel efflux restores the resting membrane potential, allowing more calcium to come in. So it's a counterbalance of calcium coming in, allowing the T cell activation. The other thing that we know that the potassium channels do in T cells is they are necessary for the migration of those cells to get to site of inflammation and within the site of inflammation.
Okay, we have a question online. So the T cell recordings, or maybe the cell line recordings, when you put on the fractions, are they from the same cell? So you have a control recording and then a recording in the supernatant. Is that the same cell or different cells?
It's the same cell. So what we do is we patch the cell, we wait for stable current, and then we add the diluted supernatant or the diluted serum, and then we wait for steady state block. And what I'm showing is the before and after on the same.
All right, thank you. So I'll indulge myself and ask a question. I think it's pretty obvious to some people who've worked on something other than potassium channels, and that is sodium channel peptide toxins. This is a pretty fascinating idea, that whether it would be possible to deliver other peptide toxins, as you've tried to do with the berotoxin, for example, that are targeting other ion channels involved in other diseases, such as NAV1.7 toxins for pain and analgesia. Do you think that might be possible?
Yes, it's something we've talked about with a few people who work with NAV1.7. The first thing we want to do is target gut pain, because that would be probably the easiest for us. Now, the interesting thing with gut pain is that it happens mostly in the colon, and we think our probiotic resides in the small intestine. So that might be an interesting localization issue. But there are also pains where we would need the drug to get in the circulation. So this is something, yes, we've been thinking about.
All right, very much, Christine.
Thank you.